Tonight we're going to continue our discussion of sex therapy. With me is Dr. Helen Singer Kaplan, who serves as head of the Sex Therapy and Education Program at the Payne Whitney Clinic of New York Hospital, Cornell Medical Center, where she has developed and directs the clinic for brief treatment of sexual disorders. Dr. Kaplan is the author of the Illustrated Manual of Sex Therapy. She also conducts a private practice in psychoanalysis and sex therapy. Dr. Kaplan's new book, You and Sex, a book on the biology and psychology of sex for young people, will be out in the fall. Welcome once again, Helen. Helen, why don't more women have orgasm?
Well, that's starting off with a direct question, isn't it? And it's true. Well, let me first give you the statistics. 8 to 10% of females in the United States never had an orgasm at all. An unknown proportion of women can only have an orgasm when they masturbate by themselves without any audience. Another undisclosed number of women can have an orgasm, but only on clitoral stimulation when they're together with a partner, and approximately 40 to 30% of women have orgasms on intercourse. Now, which part of that segment do you want me to talk about?
I'd like to first for you to talk about the woman who has never had an orgasm.
Okay. That is, of course, the most severe inhibition of function, and that really clearly constitutes a patient population. I mean, these women really do need help because there isn't anybody who can't have an orgasm. Let me correct that. Maybe 2 or 3% of people in the United States have women in the United States have an organic problem. Born without a clitoris or have advanced diabetes or taking some drugs. But the overwhelming majority can have orgasms if they're stimulated properly and if they learn to let go. Not having an orgasm is a failure to learn to let go at a certain level of sexual arousal. And that's usually due to repressive upbringing and very strict message, either verbal or nonverbal, about masturbation.
How do you treat these women specifically?
Well, first of all, I do again a thorough evaluation, which is always very important with any sexual problem, and I find out whether they put any special symbolic significance to the orgasm. And if they do, that has to be worked out first. Otherwise, if you directly attack that problem, you can get depression and anxiety and guilt in a woman. But
do you recall an example of the symbolic significance?
Oh, yes. Some women feel they will go crazy and lose control. I've had others who have dreams of being murdered when they get close to orgasm. Otherwise, they feel there's some unspoken danger in letting go of control enough to really experience an orgasm. Certainly, some men have that problem also. It's not only confined to women. Others think unconsciously or close to conscious, if they let go to a man that much, then he'll abandon them or hurt them in some way. It's a fear of abandonment, a fear of losing control, which is usually at the bottom of it.
Is it common?
In non-orgastic women,
yes.
Yes. Other women simply have not touched themselves, have never allowed themselves to stimulate, go through the normal masturbatory stage that we're all supposed to go through, and they just need a few sessions of simple teaching. More likely than not, women are afraid of the fantasies they have or are guilty about the fantasies, because you can't have an orgasm on masturbation without a fantasy. You have to accompany the stimulation with some fantasy, and they're more guilty and ashamed and upset about the fantasy than about the stimulation, so you have to work that through. But principally, the main, after you work through some of these emotional blocks, which can be done in a session or two in most instances, they're not deep necessarily, except in very sick women, then you simply teach the woman how to stimulate herself. In other words, you make her go through a masturbatory stage when she's all by herself and doesn't have an audience and isn't worried by thoughts, oh, it's taking too long and he's going to get tired and so forth. And you really teach women to masturbate first.
Do you advise the use of a vibrator in those circumstances?
Only if manual stimulation is not sufficiently strong. I first try the finger, If that doesn't work because the inhibition is too massive, I certainly will suggest a vibrator if that's within the person's value system. If it isn't, I wouldn't. You have to respect the person and their value system when you do this kind of work. To some people it's an abomination to use a mechanical device. Other people say, hey, that's cool, and they're very interested in using. You can't, so you have to really think, be sensitive to the woman's value system, and her husband's as well. Some husbands get very threatened by the vibrator, and you do more harm than good by suggesting it because he'll be very threatened.
Some women also get hooked, you told me, on vibrators.
Right. Sometimes if it takes a vibrator to produce an orgasm, the woman will experiment and experience the first sexual pleasure she has in her life, and not surprisingly doesn't want to give up that vibrator, and then we have to wean such a person from the vibrator. Not that healthy sexual people shouldn't occasionally, if it's within their value system, use a vibrator, but you shouldn't use it all the time. You shouldn't have to rely on it all the time.
Now, what about the woman who is not orgasmic during intercourse?
That's one of the great controversies in medicine.
And also in the women's movement.
I imagine so. That was one of Freud's great mistakes. He knew nothing about physiology, and he didn't understand, and many people, many men still resist the idea that the sensitive trigger to a woman's erotic response is the clitoris. It's anatomically exactly analogous to the tip of the penis. The same nerves supply the same sensation, and nobody is very upset that the male orgasm is triggered off by stimulation of the penis, although the orgasm proper really occurs deep inside, in deeper muscle of the pelvis, on the floor of the pelvis, and the same muscles produce an orgasm in a female, but they're surrounding the vagina. Nobody gets upset that the male orgasm is triggered off by stimulation of the penis, but everybody seemed to get terribly upset about the idea that it isn't the vagina that needs to be stimulated, but the clitoris. And for many years, psychoanalysts in particular thought that women who couldn't have an orgasm during intercourse were sick and neurotic if they were erotic in their
hated
clitoris.
man or something.
Had penis envy,
Yeah.
and hated men, and so forth. And of course that isn't true necessarily. It could be true, but it's certainly not often true. It's just that the natural trigger point for the female orgasm is the clitoris. Now the clitoris does get stimulation during intercourse, but rather mild mechanical stimulation. There's some traction as the penis moves in and out. For most women, it's a very enjoyable experience to have an orgasm through intercourse, but they certainly, when asked, there was one big study Dr. Fisher did up at Syracuse, and he asked 500 normal women which they preferred, and 2/3 preferred clitoral stimulation to vaginal stimulation.
This is still frowned upon, isn't it?
In some circles, but less and less so. Certainly one of the things in sex therapy, we teach women not to be ashamed if they enjoy clitoral stimulation, but to freely express that. Now, I do want to say that women who can have both kinds of experience, those are the really lucky ones, and they have the fullest sex lives, of course, do like the idea. It's emotionally very satisfying to have an orgasm and intercourse. I'm not trying to take away from that, but a woman may be perfectly normal and be multiply orgastic and a perfectly satisfying sex partner if she requires some clitoral stimulation for her enjoyment and for her orgasms. And that's been one of the great controversies and misunderstandings.
What is the prognosis, Helen, for the completely inorgasmic woman?
It's practically 98% to a point of masturbatory orgasm. But of course that in my mind isn't a cure, it's a step along the way. I would feel better as defining as a cure if a woman can have an orgasm together with her partner, if she's trusting and relaxed enough with her partner to be, so they can have orgasms, give each other orgasms, or have orgasms in each other's presence. That's a slightly lower percentage. Depends on the nature of the relationship and her trust of men. Now, as far as we also can take a woman who doesn't have coital orgasm and intercourse, and I can't give you the percentages in that varies, but many such women can be taught with special techniques to have an orgasm during intercourse, if that's
So
what
that-
they desire.
So that once a woman seeks the proper kind of help, it's a very hopeful situation.
It is. But those women who, even with the best kind of help, can't have an orgasm and intercourse are not necessarily sick. They can have super sex, and if the couple accepts that, clitoral stimulation not as a second best means, but as a good and healthy means of sexual expression, they can have a very good sex life. But then sometimes a male is insecure and feels that unless his penis gives the woman the orgasm, he's less than a man, or she won't really love him, and these kinds of emotional feelings have to be worked through.
This reminds me of something we were talking about last
Yes.
week. We brought up the fact that a lot of what you do leads me to believe that you think you're making women take more responsibility for their sexuality. Is that correct?
Mhm.
How does this sit with the husband? How do men respond to this?
In a variety of ways. Initially, some men may be very threatened, and they may say, "I don't need instruction, and I don't want to hear all this talk. How can we make love with all this talk?" But that's really rather rare, and it may be because the woman is expressing herself in an aggressive or defensive manner. Actually, men like active, interested sexual partners more than very passive partners. Throughout history, men have sought out very active women. Haven't always married such women, but have sought them out as sexual partners. And if a woman is more abandoned, also a man usually takes enormous pleasure if he sees that his partner is really enjoying herself, that she really abandons herself and is able to really enjoy herself. That makes him feel good, and that adds to his excitement, so that the ultimate outcome of having a woman more active, more responsible, more mature sexually, except in those cases where you're really dealing with a very frightened and insecure man, usually has a very happy outcome for both. Sex gets better for both.
Have you heard of this total woman thing that's sweeping the country?
Yes.
What do you feel about that, and how does that fit into all of our sort of sexual awareness?
Well, I have mixed feelings. I guess you expected me to condemn it completely, but I can't. There are certain things that are very bad and alienating about it, because it suggests that the woman play a phony role and manipulate the man by childishness and guilt-provoking. That's, of course, terrible in any relationship, human relationship, organizational relationship. Any relationship built on manipulation is, of course, inherently vulnerable. However, there is one part of it which is pretty good, and that is, it says to the woman, stop being so narcissistic and self-involved and start thinking of the feelings of your partner and what he might like, and that's to both their benefit.
But isn't it true, though, that mostly women have taken the passive giving role in sex anyway?
They have taken a passive giving role out of fear of rejection, not out of a genuine sensitivity and desire to please. You and I are being very sensitive and nice to each other, but that's not because I'm afraid you'll never invite me back on your program again. It's because I really like talking to you and you to me, and that's an entirely different thing than if I were very worried I'd have to say the right thing, I wouldn't get asked back on the program again, and that's perhaps a good analogy to what used to go on in the bedroom.
You say in the book that the outcome of sex therapy depends on three things. One is the nature of the dysfunction.
Mm-hmm.
The other is the quality of the relationship. And I think I've forgotten the third, but I'd like you to talk about the three of them, and the quality of the relationship especially.
Okay, the nature of the dysfunction, there are, as I said, there are 6 dysfunctions, 3 of male and 3 of females. Just to recapitulate the biology of it, the sexual response is divided into arousal and orgasm, and these 2 reflexes really can be inhibited separately, and that gives you the 6 dysfunctions. In the male, if the erection is impaired, then you've got impotence or erectile dysfunction. The prognosis for that depends on the severity. If a man has always been impotent all his life and is now middle-aged, chances are only about 40 or 50% that he can be helped, but they are that good. If a man has recently become impotent, the chances are in the 80% that he can be helped. With premature ejaculation, which is a failure to have adequate control over the orgasm reflex, the chances are up in the 90s that a man can be helped, no matter what the quality of the relationship or the other problems are. Retarded ejaculation, which is very analogous to the woman who has trouble having orgasm. Those are men who either have trouble orgasm or don't feel their orgasms correctly. That, again, depends on the severity. In the mild cases where a man can have an orgasm on extravaginal stimulation, oral or manual stimulation, but not in the vagina, that has a pretty good prognosis in the 80s. In the severe cases where a man has never had an orgasm in his whole life, that's a pretty poor prognosis. In the middle range, where a man maybe doesn't feel the orgasm, or sometimes doesn't feel his orgasm, or sometimes has trouble, they have a pretty good prognosis. I guess you're interested in the female dysfunction. Well, one is uniquely...
No, I'm equally interested in both, and we
Okay.
eventually are going to deal with the male dysfunctions.
Good. Well, the female also has 3 dysfunctions. One is vaginismus.
Which we haven't
Vaginismus.
mentioned yet.
Right. Well, it's fairly rare, fortunately. And that is a conditioned reaction of the vaginal muscles where when anything gets near the vaginal entrance, they just snap shut. It's not a voluntary response, it's a conditioned response. And that's also usually accompanied by sexual avoidance. A woman is very frightened. That can come from causes that are unknown, or it can come from an early and brutal rape experience, or some brutal attack, or some pain, some pelvic pathology. If it's purely psychogenic, that has a 90% chance of being rather rapidly cured by sex therapy. The non-responsive woman, as we talked before, has a mixed prognosis.
Now, what is the quality of the relationship?
And the orgasm
Yeah.
response is a very high prognosis for learning how to have an orgasm in the 90s. So that's the nature of the dysfunction. Now, the quality of the relationship.
Yeah, and its relevance to the success of the therapy.
Well, if you're dealing with vaginismus, or with, well, let's see, if you're dealing with premature ejaculation, the relationship has very little bearing on whether a man can be successfully treated. That seems to have little bearing on anything. Some bearing. If a man is afraid, for example, the few cases of failure that I've seen in premature ejaculation have been because of the disturbance in a relationship. The man was really afraid to let go. He was afraid to really engage in full sex with his wife for a number of reasons. If you're dealing with unresponsivity, also orgasm has little to do with the quality of the relationship. A woman can learn to have an orgasm pretty independently of the relationship. But when it comes to responsivity, and from really feeling a lot of pleasure, and from potency, then the relationship is crucial. If the parties are not attracted to each other or are hostile to each other, no amount of sex therapy is going to give them a good response. As you know, some men just don't turn you on or repel you, and there's no amount of sex therapy that can fix that or should fix that. You should respect those feelings.
Let's talk about one of the male dysfunctions, so
Okay.
retarded ejaculation. First, I think maybe you defined it a little bit, but maybe you can be a little more explicit
Well,
about
it's
it.
exactly analogous to the woman, the anorgastic woman. By the way, you asked me about treatment, and I should tell you that one of the most successful forms of the initial stages of treatment is groups. Anorgastic women's groups, where 6 or 7 women, we run those at the clinic, for example. 6 or 7 women have never had an orgasm.
Is that something new?
It's relatively new. But the group process is actually facilitative, and everybody goes around and tells their fantasies of what they're afraid of and having an orgasm and their dreams about it. And then everybody goes home and tries it, and then they come back the next week, and some will say, hey, I had an orgasm, but the other women will be encouraged by that, and they'll exchange information, and that's probably one of the most successful ways of teaching women to stimulate themselves. After they've reached orgasm by themselves, then they're treated individually, as a couple then, to bring the orgasm in the relationship. Now, we don't have that for men yet, which is that's a sexist discrimination, because men are not so quick to admit that they have orgasm problems. They can hide that. they can't hide erection problems. They're kind of forced to seek help with that. But many men won't admit to their partner they didn't feel their orgasm, or they may fake an orgasm if they can't have one, just the way women do. So that's a dysfunction which is only coming out of the closet rather recently. And we do the same thing. We teach first self-stimulation. We try to relieve the man's guilt about having fantasies, encourage fantasies while stimulation, and gradually bring the orgasm from self-stimulation closer and closer to the vagina.
A sort of behavioral thing.
Very behavioral, but as he gets each step closer to the vagina, he very often has all kinds of anxieties and guilts, and the couple start quarreling, and resistance may come from the woman. She may get frightened. And then you have to deal with that very carefully in the session, or you can do a lot of mischief.
You startled me, I must admit, because I didn't realize that that was one of the problems, that men can fake an orgasm. I didn't realize that.
In fact, sometimes a couple will show up at a fertility clinic because they haven't had any children for 4 or 5 years, and then it'll be discovered the man has been faking, and maybe has his orgasm alone on masturbation away from his wife, and she never knew it, and he never admitted it. It only became apparent in the sterility workup. Men have a great deal of difficulty admitting that. That seems to be a very sensitive topic.
That seems to be true for both. I mean,
Yes.
for as long as we could remember, women have been, not admitting they weren't having orgasms.
But women seem to have a different motivation, I think. A woman is afraid of being rejected, of not being a good sex object, of the man will think she's not responsive, she's frigid, and he won't be pleased, and he'll leave her. A man is more afraid of admitting some kind of performance failure.
Mm-hmm.
Little boys in our society are unfortunately taught that they have to be performers and producers and always look good and always put on a show and always look terrific. And that's a terrible burden to carry. And that's more why a man might hide that. A woman is taught she has to be pleasing. I'm oversimplifying terribly, of course, but a little girl has to be pleasing and pleasant, and that's what she's more afraid of.
Now, what about premature ejaculation? Can you describe that? What are the symptoms?
Sure. The normal male learns after the first few initial sexual experience to have voluntary control over his orgasm reflex. Now, some reflexes in the body you can never have voluntary control over, like erection or lubrication or heartbeat. But there are other reflexes we do, like defecation, urination, and orgasm. And if for some reason the man is too excited or too distracted at the moment of high sexual arousal, he never learns control. And he robs himself and his partner of a great deal of pleasure thereby. And the treatment consists of it's a training procedure rather than real psychotherapy, where a man is brought to a height of arousal by his wife, first manually, with the use of a lubricant, to a height of arousal, and he stops, learns to identify those sensations, and then he lets the sensations go down for a few seconds and up and down, and finally he has his orgasm. It's really a training procedure, and then this is done inside the vagina. And again, we get enormously high success rates with that, although it can be emotionally very intense experience. It can be a very intense experience for both. The partners are more likely to get upset than the men.
Why are the partners more likely to get upset?
Well, because if a woman is insecure, she'll say, okay, now I'm helping him overcome this symptom, and now he'll go out and find himself 3 other women and leave me. And the other reason is then the woman has to face her own sexuality. She's been saying, well, I don't have orgasms because he comes in 2 seconds. As he gets longer control, she has to face herself and her own inhibitions, which is sometimes pretty hard.
Is it typical that problems occur after success, or problems occur because of success in treatment?
Well, that's a big argument in psychoanalysis. Psychoanalysis is very suspicious of even curing ulcers because that's a psychosomatic disease in many cases. And symptom removal we're very afraid because nobody wants to harm a patient. And the rapid cures and behavioral cures were looked upon with some suspicion, because according to psychoanalytic theory, if you remove a symptom, you might harm the patient. It might come out in some other form, or a patient might get very depressed and anxious. And indeed, that does happen in a small percentage of cases. The sicker patient, I'd say, in my experience, around 5 to 10% of our patients do become, at least temporarily, either depressed or anxious or develop other symptoms.
Can you give me an example, for instance, how a woman might respond after successful treatment of her husband's premature ejaculation?
She might go into a profound depression, or get very paranoid and jealous, call him at the office 10 times, make sure he's really at the office and not out somewhere, and she might get bad dreams, and she might then just fear abandon, get very paranoid about his abandoning her, get very hostile. But you can deal with that if you're sensitive to that. And but most of the time, the couple feels either the same or much better after their sexual functioning improves. It's rare that a person or a partner, but it's not unheard of, will feel worse. The same is true with the relationship. The relationship may improve, usually does, with the increased communication. The whole process, not just the outcome, but the whole process of therapy entails greater intimacy, less anxiety, more communication. But sometimes, usually the relationship improves.
Helen, do you think we have a proper perspective on the importance of sex in this country, or do you think we have only a few seconds? But I wanted to know what you think about what our society's attitudes. I mean, are we being misled? Are we being taken down the garden path?
Well, we have a whole mosaic of attitudes. Some of us overdo it, and some of us underdo it, and most of us admit we really don't know exactly where we would be if we were left alone.
Thank you, Helen, very much. Thank you for watching, and good night.